So you'll just peg. So we're going suprasternal notch with this one down to just above pubis. It would be adjusted a little bit longer for Rob to fit there, and the side arms come around to provide a lock there. But this is not gauged to be lateral flexion control. This is gauged to be anterior posterior control in this way. Forward flexion, extension, it will stop and limit that severely, but it will not control. It's not designed to be used to control sideward flexion in that fashion. This would be where you'd be moving on to one of the other braces. So this would be, if we rotate you around up there, the pad would be adjusted. If we spin around here a little bit more, Rob, there, again, a long strap can be adjusted. The straps can be trimmed for length. As you can see here on the long strap here, there is a tab here. And the reason for the tab is that you want to decide which side you're going to be eventually, if the patient's going to keep it longer term, which side they're going to be opening the brace. In this case, we're going to say Rob's going to open the brace from the left side. So we fix the right hand strap, which is adjustable but not trimmable. This one tabs off so that you can set the length to the perfect length for the patient. So you cut the strap length to suit yourself, and then we would tab it back on to the Velcro onto the strap and pull in. But the pad itself on the back is a lovely thick moldable pad and flexible, as you can see, to take the patient's shape into account. And equally, as I say, you can put the plate lengthways or horizontal depending on what you want to achieve and how the patient feels about the brace. You can try it both ways and see which way the patient feels more comfortable. If we rotate you slightly around, Rob, again. Wing up, and we would put through the loop and pull and stick the brace on you, that fashion. Through here. So I've put this really close to the edge so that Rob could reach it and undo it there. And if Rob were to sit down, what we're aiming for with this brace is, once Rob's got the brace on, if he sits down on the chair, we're aiming for suprasternal notch here, and we're aiming for sitting on a firm chair. You can't tell patients to go home and sit on slumpy couches like they might normally do. The first protocol is switch the patient with the brace to a nice firm chair that they've either got at home, an armchair or something, but not the slumpy couch most people have to go home and try to sit on that, because obviously what's going to happen is they're going to flex their thigh up above 90 degrees, and that's going to then have to shorten up considerably to achieve comfort, which is grand until they stand up, and then you find that that pad, instead of being here, is somewhere up here by navel level, which is just far less controlling of the whole condition. So you're setting the patient so that when they sit, as you can see, we're just sitting that pad so the patient can sit with a flex at 90 degrees to sit. You can sometimes have to play with cars, but often if the patient is using it in a car, I would say get a car cushion, because of course very available now are car seat raisers, not like a child seat, but a sort of mini cushion that goes on the seat, or even a firmer seat that sits into the car seat to position the patient so that when they sit in the car, they're not slumped down and that. And a lot of cars these days, of course, have got adjustable seats, so you can adjust that seat to get that seat angle correct. So those ergonomics for patients are really vital in using the brace successfully. And that's what they want to see the patient utilising the brace if they are long-term users, and not returning to clinic with a pile of problems that actually would be solved by the right information being given to the clinician and the patient in the first place. So these are the sort of things I'd be talking to the patient about when I'd fitted the brace. It wouldn't be just simply stabilising forward flexion for degenerative changes or stable fractures for the while. It would be the ergonomics of moving into the community, that sort of thing, and using the brace a long term. Now what do you have to do? Because they would not know these things unless you told them. It's not something that crops to people's minds. So we can stand up and we take that brace off. And again, this is a situation, if it's a stable fracture that you're using that for, that's perfectly fine to use it for that between the levels, as I said, of T6L2. The reason for choosing different braces gets down to be preference of the practitioner. So why there's a range of braces and why use a different range of braces. They have different levels of control from this one, of course. The next braces up have got more control than this, but this is a good one, very good brace, especially for patients who are long-term users, who are wanting some level of stabilisation in forward flexion extension in the community. But can be used quite frequently on wards to stabilise the stable fractures within that level also. But it's very individual to the consultants, and they also gauge the patient as well. So they're taking the psychology to some extent of the patient into account. How compliant is the patient for? Are they taking all the information on board? Are they obviously going to play ball with the treatment regime that's been set for the patient? If they're not, and you can see that they're going to be getting into trouble because their attitude towards the brace isn't correct for what you're anticipating, you would put them into more rigid bracing and lock them up, because that way when they've got the brace on in any fashion, you know they're not going to get into trouble by that. But you're often aiming for patients who are compliant and would use the brace in the right way and take that on board. That's where this brace can come into fashion. And of course, the pectoral version has the same strap. That's simply just for comfort over this region, as we've discussed. Again, taking the pressure here, but fitting exactly the same otherwise, and utilising the same protocols in all ways otherwise, but that does not give the same pressure over the sternum, and it can sometimes obviously be a deformity to the sternum as well. Sensitivity, different conditions, medications can create sensitivity over the sternal plate, which is uncomfortable for patients. That's the alternative to the same regime. Patients would, or even claustrophobic sensations can happen sometimes, and this alternative is always the winner when you get into those situations. Both will give the same control. There isn't one better for another. There's just different slight features from one to the other to achieve the same result.